Hello, welcome back. Today is session 10. We're getting close to the end of the semester, and we're going to start talking about airborne diseases. Specifically, we're going to talk about tuberculosis and influenza. However, be aware that there are many other airborne diseases that we're not going to discuss, such as uh, respiratory syncytial virus and some of the many others that are out there, common cold, that have global health impacts, but we just don't have the time to discuss them. So for purposes of this lecture, I'm just going to discuss specifically TB and influenza. And so let's get started. We're going to start with TB. Tuberculosis is a disease where 2 billion people are infected with the microbe that causes TB. This is a huge amount of people. However, you must be aware that not everyone develops the active disease. A person is infected every second globally, but most people do not present with major disease. It's evident in 22 countries that account for 80% of all cases. 50% of the cases are in Asia, and about 28% are in Africa, which also has the highest per capita prevalence. So even though Asia represents a higher number of people, because the population is much larger than Africa, it actually has a lower prevalence per capita. In 2005, there were 8.8 million cases of TB and 1.6 million deaths from TB. That's about 4,400 per day. The major characteristic of TB is that it's highly stigmatizing. There's been other names of it called consumption because people tend to get very thin and emaciated as a result of later on stages. And it's also characterized by vomiting of blood, which is a very common characteristic that causes a lot of the stigma issues. We'll get into some of the characteristics, symptoms a little bit later. If you look at over time in sub-Saharan Africa, you can actually see that the per capita incidence of TB, the incidence of TB per 100,000 people has actually been increasing over time between 1994 and 2005. And this has been mostly related to the increase in HIV, actually, that's been going on, making TB much more prevalent. If you look at TB prevalences over that time period, that was, as before the onset of these HARRT or heart therapy for HIV, and very good programs to prevent tuberculosis and treat tuberculosis as well. So in the late to mid 2000s, as those global programs for HIV and TB became more prevalent, these numbers started to stabilize. If you look at the global incidence of TB, you can actually see here that most of the cases are in sub-Saharan Africa, but you have a good percentage of cases in the old Russian republics. And what's interesting about these cases is that they tend to be drug-resistant cases. We'll get into some of that as well. The drug-resistant cases actually present a very large problem in combating TB throughout the world. So what is the life cycle? So you get a primary infection. Typically, it's, again, a respiratory disease. Someone coughs. You have to be aware that TB is not extremely infectious, so you need a large amount of particles to actually get an infection, and a huge amount to actually get an actual infection that results in disease. But what will happen typically is you'll get a primary immune response, and the TB will actually go latent. It'll hide in the lungs, and that can hide for an indeterminate amount of time. During this time, certain types of therapies are not valid. The isoniazid therapy is not advised at that time. And then other risk factors such as HIV, they call it stress factors effectively, will lead to what's called reactivation. And this can happen at any time throughout the person's life. And typically you'll either have two courses when you have reactivation. You can get cured of the disease through therapy or through your own immune system, or about 50% of people end up dying through the disease immediately. You can also get relapse later on once the person is cured. They may still have some that's been staying latent, and you can get reactivation multiple times as a result of that. If you survive the disease and you're actually able to do what's called cavitation, in which the bacteria will then actually cause a capsule around, your immune system will cause a capsule around the bacteria to prevent it from being able to transmit. If that capsule basically bursts, you can get reactivation of the disease, and then you can actually transmit the disease during that time period. And so that's effectively the life cycle of the bacteria. So the transmission, as I just showed you, The transmission symptoms of active TB include cough, which can last 3 to 4 weeks, even sometimes more, and spitting up blood is the major visual characteristic of it. You get significant weight loss, you'll have fever, night sweats, and that'll last for a certain period of weeks, depending on how your immune system is able to withstand it. The symptoms may also include fatigue, feeling unwell, loss of appetite, chest pain, shortness of breath, and difficulty breathing. You can see a lot of these are very palindromic type of symptoms in which you really can't, they're nothing really special designed for TB. It's really the sputum in the blood is one of the major hallmarks of it. It's caused by the bacteria, we talked about that, but the bacteria is called Mycobacterium tuberculosis. It's actually quite well related to leprosy. It has a lot of, it's Mycobacteria leprae. It's the same, from the same family, different species, but it's in the same category. Although TB can infect any part of the body, it usually infects the lungs, which leads to pulmonary TB. And most patients have TB in the lungs. Besides the lungs, it can affect other areas, including lymph nodes, brain, kidneys, and bone. However, that is relatively rare. TB is spread by airborne particles, which may be expelled when the person sneezes, as showed you before. And what it usually leads to is after the primary infection, you usually end up in TB as a latent infection, as I mentioned. It hides dormant in the lungs for an indeterminate amount of time. Once it is activated, you get an active type of TB in which you are infectious to other people, and you have the sputum will actually test positive for sputum smear. So if you take a piece of sputum, and actually put it on a microscope slide, you can actually see the bacteria at that point. Typically, we'll get into some of the tests for it. Some of the factors that increase risks include HIV or immunosuppressed people in general. People who have low immune status and poor health in general, such as diabetes, malnutrition, they're also more likely to get the disease. So this can affect, if you have people in developing countries that are malnourished, they have a higher incidence and a higher chance of getting this disease. So the diagnosis is typically done through laboratory techniques. Sputum smear samples is what I mentioned before, is where you take a piece of sputum, and you put it on a slide. You add a stain to it, and you can actually see the bacteria. You can see them like the little tiny purple lines in the top right picture. Another way you can do it is through using laboratory cell culture. This is a much more definitive way of determining what it is. However, it does take a long time. The bacteria grow very slow, so you need to make sure that you have the time available. If the person is HIV positive, or they are in special cases where you might think that it's a drug-resistant strain, you might want to start treatment before you even get that type of test. And then there's also the tuberculin skin test, which is a way that you can detect if a person's been exposed, but you can't determine whether it's a latent or active infection. This is very usually, most of you have had this, where you basically stick the tuberculin protein under the skin and you look for a bump or swelling, and what you're looking for there is an immune response against that protein. The protein itself is not infectious, it's just a protein from the TB bacteria, but it actually will cause that swelling, which will give you a sign that you've been exposed at the very least, in which case you need further testing. So the treatment, I'm not going to get into all of the treatment techniques. We're just going to, or the particular drugs, but just be aware that there are certain regimens. They are very long regimens. They last between 6 and 8 months, and they require up to 4 drugs. They're taken daily for the first 2 months, and then the 2 remaining drugs for 4 to 6 months after that, depending on the sputum conversion during the course of the treatment, and then also depending on whether you have a resistant strain, infected with resistant strain or not, can actually affect which drugs you end up taking. The strategy that's used is a strategy that's being employed now with a lot of other disease, but TB was one of the first ones that actually utilized this strategy, called directly observed therapeutic treatment, or directly observed treatment. And then sometimes you'll see it as dots, or sometimes you'll see it as dots with the S. And basically what it is because the regimen is so long and so complicated, a lot of times to make sure that people are taking their drugs appropriately over that course of time period during the regimen, you want to actually watch them swallow the pills. And so what you'll do is you'll have them come in once a day and to the hospital or to the local health facility and actually distribute the drugs every day, basically, to that person, and watch them take it. The reason this was done was because in the early days, the WHO started to recognize that drug resistance was forming, and so they developed the DOT strategy. And it's been adopted in almost every country in which has TB as an infection, and then in all 22 countries that have it as high burden. It's being implemented and has been shown to increase cure rates up to 95% and prevent further transmission by curing the patients. It's also been shown to be fairly effective in HIV-infected patients. Those patients tend to have a weaker immune system, so the drugs are much more critical in the survival of the people infected with HIV versus just allowing their own immune system to take care of it. So you can see some of the drugs here. There are the fixed dose combination, and typically, I just want to show you what they'll do is they'll typically package them in these blister packs. The blister packs you would see on the bottom right here, in which they would just give it to the patient, and the patient would take one pill every day from each blister pack, or even they might even have them combined, where there's 4 pills in each blister that they'll pop out, and they'll take all 4 drugs at that time. So another concern that you need to be aware of is because of what's happening with they're calling it multi-drug resistant TB has becoming active fairly well especially in the Eastern European countries, the old Soviet countries. What you're getting is that they've become resistant to the first line and second line drugs, and now you have to actually give them some of the more complicated drugs. What's even scarier is there's a new form that's been coming out called XDR, which is extremely drug resistant, and that is almost resistant to every single drug that's available for TB. And these patients are extremely, I'm going to use the word dangerous. They're extremely dangerous to the population because they can spread the disease fairly effectively, and if they do spread it to a lot of people, this XDR strain can become a major problem throughout the world. So catching those people, isolating them, and giving them the only available drugs, which is extremely complicated and extremely expensive, is the only way that we can deal with it. The drug-resistant strains have a greater health threat on HIV patients, for instance. It's common, it's throughout the world, but it's very uncommon in some areas. It's, like I said, more common in areas such as Eastern Europe. But it is found in greater than, among the MDRs, about 4% of all cases. XDR, you only have about a handful of cases throughout the world so far, but that's a very dangerous area if that starts to spread. I'll show you a slide where that demonstrates how many people have been infected with each of these in a couple seconds. And then here is the first one. So this is where MDR is. This is multi-drug resistance. So they are, again, they are resistant to the first-line drugs, but they are susceptible to the second-line drugs. And so these people require much longer regimen, and they have to be monitored much more closely, but they can clear the disease with proper treatment. And you can see vast majority of the cases tend to be in India and China. Sub-Saharan Africa is getting a couple, and you can see even here in South America, Peru has a concern in the Americas anyway. But that is basically the global cases since 2002. For 2012. If you look at the percentages of the new TB cases with MDR over that time period, you can see that Eastern Europe and Mongolia, Eastern Europe, Western Asia tend to be where most of the new cases are coming from. So we talked about some of the issues about MDR and XDR. Just be aware that it entails a strategy that is much more complicated. It uses the second-line drugs. They're much more toxic. They have more serious side effects, and they're much more expensive. The average MDR case can cost between $5,000 and $8,000 per patient to treat. Just as a comparison, the average regular drug-resistant TB is only a couple $100s to treat. If you start getting into XDR territory, that price even goes up further. An average person that has XDR TB can cost up to $100,000 to treat. So it's extremely complicated and can get extremely expensive. One of the other complicating factors beyond just drug-resistant strains is HIV. A third of all the people living with HIV are co-infected with TB. It's 200,000 that die annually from the TB. They have the HIV, the TB is what kills them. It is the most common opportunistic infection in Africa, and for that reason, when you start looking at organizations like the Global Fund for HIV, TB, and Malaria, you might be thinking, well, why are they including TB in this? And that's one of the main reasons, is because it is one of the biggest cofactors for HIV. 70% of TB patients are infected with HIV in some countries of Africa, so again, you see this massive overlap between HIV and TB. And TB is harder to diagnose in HIV people, mostly because you don't have the immune cells. When you do that, the tuberculin skin test, for instance, it might not show up as effectively. If you're doing if you're doing the other type of tests, molecular tests, they may not show up as well. It progresses faster in people with HIV. That kind of makes sense. They don't have the immune system, so it does nothing to stop it. TB and HIV infected people is most certain to be the cause of death if left undiagnosed or left untreated, and it occurs earlier in the course of an HIV infection than other opportunistic infections. So if you have the TB, it could wipe you out and kill you much faster than, say, what would people normally die from, like flu or some of the other diseases. As I mentioned before, the Global Fund, but also if you look at the Millennium Development Goals, I talk about the Millennium Development Goals, but yet they are pretty much done. Now they're starting to look at the Sustainable Development Goals. The MDGs are going to be finished in 2015. So you can see some of these were the original targets that they had for TB. Target 6C was to have halted by 2015 and begun to reverse the incidence of malaria and other diseases. That includes TB. 6.8 is incidence and prevalence and death associated with TB, and 6.9 is the proportion of TB cases detected and cured under DOTS. Almost none of these have actually reached the Millennium Development Goals where they wanted them to be. Some countries have, it's country by country, but as a whole, the whole world has not reached these goals. And in the Sustainable Development Goals, a lot of these will be reiterated and trying to get to these points for these targets. If you look at, again, here's the HIV and TB incidence area, prevalence, you can see that again, wherever you have HIV at the high prevalence, you also have a high prevalence of TB as a co-infection, and mostly sub-Saharan Africa. For the rest of the world, where there's a low HIV prevalence, you can actually see that the co-infection is relatively low as well. So what are the challenges? We've talked about other diseases now in great detail, and you can see that the challenges are going to be pretty much the same. Lack of political will and commitment at all levels of TB control, weak health systems, that is going to be a problem with every disease, lack of adequately trained personnel, workforce, lack of supplies and so on, inadequate TB drug supply, inadequate supply of vehicles to distribute it, education materials and so on. HIV co-infection is another major issue as people start to get more and more on HRT therapy, HART therapy for HIV. They're going to be co-infected with TB, so you need to be aware of that fact. Insufficient technology for diagnosing. The vaccine BCG, I didn't mention that up till now, but the BCG vaccine is a terrible vaccine. It's not very effective in treating. I think it has a 40% efficacy, between 40 and 80% efficacy, and so they need to develop a much stronger, much better vaccine. Multi-drug and XDR TB are also major hindrances and need to be monitored closely. And then limited collaboration with private providers. So because this is long-term treatments, a lot of healthcare providers, whether it be in the private sector or public sector, don't necessarily want to pay for the treatments for that long of a period of time. So getting them to understand the implications of what they need to do and getting them to do that is extremely critical. So some of this global prevention strategies, the goals and strategies I mentioned before, the MDGs, but the TB organizations also have their own targets. The global TB control targets by 2015 are to diagnose 70% of the people with sputum smear samples and cure at least 85%. They're getting close to that, but they haven't reached it yet. By 2050, the global incidence of active TB will be less than 1 case per million per population. That is the term that they use in this case for elimination of TB. So they want TB to be eliminated as a public health concern by 2050. Be interesting to see whether they get to that. I'm hoping they will, but time will tell. The WHO defines the treatment success rates as the sum of TB cases where they're cured plus those cases that completed treatment, but yet no laboratory confirmation of cure has been determined. So it's a washed way of saying that they want that you've cured someone. If you haven't confirmed it, you don't know for sure. The best TB prevention and control measure is finding and successfully treating all cases by sputum smear samples and people that have pulmonary TB, active pulmonary TB. Expanding the case number is done in programs by achieving good cure rates. This approach minimizes the number of inadequately treated TB patients, making sure that they take their therapies. Using DOTS method is extremely important. And then healthcare providers can protect themselves against TB infection by using masks and collecting or handling sputum very carefully. So proper laboratory technique is another strategy in educating healthcare workers on that. The BCG, they need to develop a better one. We left it at that. So what are the components of the TB control strategy? I'm going to talk about the U.S. strategy for global TB, but a lot of countries have the same strategy. So in 2006, the United States developed the Stop TB program. It was a 10-year program that's going to end again this year. Everything seems to be ending in 2015, so you'll start to see the 2016 to 2030 plans come out soon. But they invested basically $56 billion, a threefold increase from the previous one. Hopefully the next version will be a threefold increase. But yet it still has an estimated funding gap of $31 billion. And you can see in the figure here where the money typically goes. Most of it, almost half of it, is going to DOTS therapy. The drugs themselves is about 6%. HIV treatment, combination treatments is about 12%. Dealing with MDR is about 12%. Developing new tools, that's the new drugs, not so much the drugs, but the diagnostics is about 8%. Health system strengthening is 7%, and then all the other stuff is 7%. But you can see here the six points of what they think is necessary to strengthen it, and you can see that also it's basically what you see in the figure is developing new drugs, empowering people with TB in communities, enabling and promoting research, promoting DOTS therapy, and so on. There are a lot of organizations, and I'm just going to touch on a couple of these. If you're interested in TB, that work directly with the program, the main one that you know about is WHO. The Stop TB Partnership is a network of partners working to realize the goal of eliminating TB, and they promote DOTS. The Global TB Drug Facility is a Geneva-based program that addresses the need for new drug research, monitoring systems, diagnostics, and so on. The Green Light Committee was established by the Stop TB Partnership to deal with multi-drug resistant TB specifically. The Global Fund for HIV, TB, and Malaria is an organization that basically funds a lot of programs in country for TB and HIV and malaria. The Global Alliance for TB Drug Development focuses on developing new drugs. They will often supply funding for drug research. And the goal of ARIS is actually a global TB vaccine foundation, and they're actually local. They're based in Rockville. If you're interested in TB research, this is an organization that's a good one to look at. And then also, if you're looking for jobs or internships, look them up. They develop vaccines against TB. I think there's a couple now that are in late stage clinical trials, and hopefully they'll be online soon. USAID has their own infectious disease department, which focuses on TB, and that's really it for TB. Now we're going to move on to avian and pandemic influenza. I'm not going to talk about just influenza, but since this is more of a public health angle, I wanted to, the avian flu and avian pandemic and pandemic influenza is kind of out of the spotlight again now that Ebola popped up, but it is something that needs to be concerned about because it can happen again. And I just thought that this is a good example of how you would talk about a pandemic and dealing with pandemics. So we're going to use influenza as the example. Again, this is the only two diseases I'm going to be talking about. I'm not going to be talking about, for instance, respiratory syncytial virus, but if you're interested in some of the other respiratory diseases, I encourage you to look those up as well. So what is influenza? Again, it's a respiratory illness. It's resulting from an influenza virus. It's highly infectious, unlike TB, and can spread rapidly from person to person. Some strains can cause more disease, more severe illness. So depending on the strain, you always hear about that yearly variation. Some can actually cause much more are much more problematic. From 1976 to 2007, the annual deaths due to influenza ranged from 3,000 to 49,000. These are U.S. numbers, and it's if you look at the global span of that, it can be much different. Every year, there's 600,000 lives years lost, 3.1 million days hospitalized, 10.4 billion. All these numbers are irrelevant for the most part, but I mean, you get the idea that it does cost a lot of hospitalizations, and causes a lot of problems. In the developing world, the cost might be lower just because no one really treats it. The deaths are probably higher on average, the death rates, and the live years lost is still probably relatively the same because people get sick and they can't go to work and so on. The types of influenza virus. Influenzas are divided into three main types, type A, B, and C. A viruses usually infect birds and other animals as well as humans. A viruses are the source of the seasonal flu, epidemics, and all pandemics. B and C affects humans only and do not cause pandemics. When you get the typical flu vaccine, you're usually getting an A and a B or a C, so that you get a combination of different kinds of flu viruses. It's not typically just one for that strain. You'll get 2 or 3 as a seasonal vaccine. So how does influenza transmit from animal to human? So typically, if you look at the genomic structure of influenza, the virus, basically it has 8 separate RNA chromosomes, if you want to call it that. They're not chromosomes, they're RNA strips. And what will happen is if you have a type of one type of influenza and another type that co-infect a bird, for instance, that bird can then have recombination events where some of the RNA from one of those virus strains to the other viral strain can form together, and actually that's how you get new types of ones. Typically, it'll be migratory birds. There's all kinds of animals that can transmit. It doesn't need to be birds, but since we're talking about avian flu here, we're going to mention birds. And then it'll transmit to domestic birds, which can then transmit directly to humans. It can transmit to livestock, and then the humans can get it. And that's the typical way it happens. The cycle that we usually get in the yearly cycle often starts in Asia and kind of just works its way around the world, and that's why it's a yearly event, and they have to design it every year. There's a lot of animal and human interactions. A lot of times the animals will live with the humans. They'll walk in and out, or at the very least, very close to the household. Humans have much more direct contact in a lot of these developing countries in Asia as well as Africa, and so it's much more easy for them to transmit the virus. So what are the symptoms? Again, this is pretty much so generic. It could be any disease, but in the initial stages, it's usually sudden onset. You typically have a high fever, headaches, muscle aches, and severe weakness. You will typically then develop respiratory systems, which include cough, sore throat, and difficulty breathing. So it is a very generic type of disease, but it can knock you out for a good 2 weeks, and even in the United States if you have it. How does it spread? Again, it's very easy to spread. It's through inhaling respiratory aerosols. Person coughs. It's extremely infectious. The next person right next to him gets it. To some degree, it can be spread through fomites. If you cough, on your hand, and then you shake someone's hand, it can be spread through that way. But for the most part, it is more of an aerosol is what causes the spread. Seasonal influenza, they talk about antigenic drift. This is an immunological term. Basically what happens is you get small mutations in the virus itself, which can actually change the antigenicity of it. And that basically changing the antigenicity of it makes it so even if you have the same virus that you got infected with last year, because of this small small mutations caused by antigenic drift, your body may not recognize it as the same variant. So you'll have to develop a whole new primary immune response against it. And this happens slowly. This rarely happens. This happens constantly, but it happens so slowly that you don't get a massive shift in the immune system, so you don't get a whole new variant, for instance. When you get a pandemic, that's typically caused by an antigenic shift as opposed to drift, which we just talked about. And these are massive mutations or massive recombinations from different viruses in which the body has never seen before, and even variants of it it's never seen before. So it can really knock you out immunologically as well as physically. So therefore, it's the antigenic shifts you need to be aware of. And they are typically worldwide, and few people, if any, have any immunity to it because, again, it's such a massive mutant or a massive change that no one really has the immune reaction to it. And it allows the new virus to spread widely, easily, and cause more serious illness. So what causes it? That antigenic shift I was telling you about, the term is called either a reassortment or a mutation, are the two major causes, which we mentioned before in that cute picture, by the way. All those cute little ducks. And antigenic shifts are rare. They happen, they say, on average about once every 100 years. So we're overdue. Our last one was the last major killer was 1976, so it's about every 20, what is that, about 30 years, 40 years ago. And about every 20 years you get a shift. So you'll get a bad year, and then every 100 years you get a really bad year. So we'll talk about some of the historical ones. And then seasonal versus pandemic flu. Pandemic flu is not just a bad flu, it's a wholly new threat to humans. And it can disrupt massively your immune system, and it can disrupt the human experience in general. Some of these flu epidemics have shifted the course of human history, for instance, because of these pandemics. Compared to seasonal flus, pandemics infect more people, cause more severe illness, and cause a lot more death. Seasonal influ do cause most severe disease in the very young and very old. But what's interesting is the pandemics typically will be the more healthy people, the people that live 20 to 40. The pandemic flu of 1918, 1919, I'll get into that a little bit, was one of those examples. So the history, pandemic flu, influenza in general, was first mentioned by Hippocrates in 412 BC. It was first described as a pandemic in 1580. And between 1580 and 1900, there were 28 pandemics. So historically, it's relatively common. You get a pandemic every 30 years about. You get a major one every 100 years. So the pandemics of the 20th century. For this century, the big one that I love to talk about is the pandemic flu of 1918, the Spanish flu. And this one killed between 20 and 40 million people worldwide. It was an H1N1. The H1N1 is the designation for how you actually characterize it. It's two specific proteins on the cells, on the virus capsid and membrane that will actually determine the H, and the variants is the number. So you can have an H3N1, and that's how they actually classify it. But the Spanish flu happened during the World War I. It was a very, very severe one. And a lot of people say that World War I actually ended not so much because of the victories in the battlefield, but because they wiped out all of the people of age that could fight during with the flu itself. In 1957 was the Asian flu. This was H2N2, and it killed about 1 million people. And then in 1968 was the Hong Kong flu, which was H3N1. The most recent one you heard about in the late 2000s, or in the early 2000s, that was actually it could have been a pandemic flu, that avian flu, but it actually was able to be stopped through surveillance much faster, the Hong Kong version of that. And you can see here in 1918, this is an example of a hospital, Camp Fuston in Kansas, which they actually believe was the starting point of the flu and spread throughout the world from there because these were soldiers that were practicing in basic training before they went into Europe for the war. And they took it with them to Europe, and the Europeans took it to Asia, and so on. And that's how they think it actually spread. But you can actually see here in this picture from 1918 the beginnings of this pandemic. So lessons from the last pandemics. The biggest thing that you realize is they occur unpredictably, and they're not always starting in the winter like common flu does. That's something that needs to be aware of for proper surveillance. If you're looking for these outbreaks, you need to have a proper surveillance system in place, a good one, so that way you can determine where it's going to happen. There's great variations in mortality and severity of illness. a rapid surge in numbers. You get this massive increase. Regular flu, you typically will get, it'll be a steady increase with regular flu, and it'll kind of top out, and then over the entire season, you'll start to have it kind of come down. With pandemic flu, it's a rapid increase, and it occurs within a period of weeks. The key lesson again is unpredictability. You have to have a good surveillance system in place to be able to detect when this type of thing happens. So why is there a concern about pandemic now? It's highly pathogenic. That meant the version I was telling you about, the Hong Kong in 1997, reemerged in birds and in humans in 2003. It's now circulating widely in birds in many countries. So it could come back. A lot of people still don't have the immune response against this one. As you can see here, it's an H5N1 is the strain for that one. Since 2003, the strain has spread from birds to humans, and by 2006, it infected 241 people in 10 countries. That's nothing in terms of from a public health point of view. But if it actually starts to spread, like we said, it spreads very fast, very quickly, very hard. So if there's 241 people, could spread it to 500 people and 500. It could be like the Ebola outbreak in 2015 or 2014 that had spread fairly quickly, and it took a long time for them to actually contain it. This could go much worse since it's airborne than that situation. The strain has long been documented to spread from person to person, so that is the major concern. And reassortment or mutation could allow the strain to easily become transmissible between humans. There's no way to know when and if this will happen, though. So what is the next pandemic? Would the next pandemic be severe? We just don't know. It's too complicated to know how bad it's going to be in the next one. Like we saw before, the 1957 version killed 1 million people. The pandemic of 1918 killed 20 million people. So you have no idea how severe it's going to be. Just by knowing which strain it is, because that one was H1N1 and this one is H1N1, doesn't necessarily mean that they're going to have the same impact on the health. So you have to kind of monitor what's going to happen specifically. And then what could happen during an influenza pandemic? In the United States, for example, up to 1.9 million people could die, 9.9 could be hospitalized, and up to 90 million people could become ill. That's almost a third of the population. With good health care, most of them will not die. You say 1.9 million out of 90 million. If you're dealing with a pandemic in an area like a developing country that doesn't have good health care, it could really cause a lot of deaths in those type of situations. So proper surveillance, proper surveillance, proper surveillance. Past experience teaches us the following. The emergence of new pandemic viruses are more likely. One wave of influenza is likely. You're not going to get, because historically we see this, like I said, every 30 years, you're not likely to get, multiple waves of this. It typically happens over 6 to 8 weeks, so you get this massive increase of people that infected, and then it comes down. The gaps between waves may be 3 to 3 weeks, maybe weeks or months, and a subsequent wave could be worse than the first. So for that reason, you have to be aware that you get these, even though the actual epidemic may be contained within 1 year, you have to, once the waves come down, you have to be aware that it's going to keep the surveillance up so that way it doesn't come back. What can be done to slow the spread of the pandemic? Vaccines, there are vaccines being developed. They are looking at pandemic vaccines that have been known to cause pandemics, but also strains that trying to find the commonalities between strains. So if you can develop a vaccine that would cover all the different H1s, for instance, if you developed an H1 vaccine, you could probably at that point remove any of the problems that come from H1 influenza. If you could develop, even better, if you could develop a pan-H vaccine, theoretically you could cure every single type of vaccine, because if you can develop a vaccine against all the hemagglutinin protein, H protein, you could actually wipe out any particular strain. So whether it's H1, H2, H3, doesn't matter what the end strain is at that point. There are studies being done for that. Antivirals exist right now, but they're very weak. Typically by the time you show symptoms for the disease, it's almost too late. So you have to, if you think you've gotten infected, the current antivirals you should be taking it already before you even show any symptoms, and for that reason, they're very ineffective. If there's a pandemic, there's likely to be insufficient supplies and for that reason. And even though the antivirals may work against the common strains of flu, no one really knows how effective it would be in a pandemic situation. The biggest thing you can do during a pandemic is probably containment measures. Quarantine is probably one of the most effective ways. Combination of that and isolation of people who are not infected, reduction of travel, things like wearing masks, all those type of things could be some of the best ways to prevent it and the spread of it. The current vaccine, because this is the vaccine itself, you wouldn't necessarily have enough doses for a vaccine. There's a lead time. They need to know what the strain is going to be before they develop the vaccine. Once they actually know what the strain is, they could probably develop a vaccine fairly quickly. Develop it in concept. Producing it is a whole other situation. There's a significant lag time in the amount of time it takes because they have to grow the vaccine in chicken eggs, and then they have to purify it out, and then they have to package it, and that could be months it could take to do that. So even if you have and since the pandemics tend to happen within weeks to early months, your pandemic may be over by the time the true vaccine is ready. So developing a faster way of developing vaccines, or not even relying on them, is probably the best way to deal with it. Second line drugs, the current one, Tamiflu, is available, but it's been stockpiled. But since the last epidemic, I shouldn't say epidemic, since the last avian flu outbreak, but for that reason, it's actually that was years ago, and those particular pills are probably expired by now. So, and it's extremely expensive to stockpile the treatments. And even if you stockpile in the United States, you might treat 25% of the population, but that's 75 in the United States, 75% of the population in the United States that doesn't have it, and then you forget about the rest of the world. Billions of people, so stockpiling it is probably unrealistic in terms of a financial point of view for a disease, for an outbreak that may not happen. The disease containment measures, we mentioned before, isolation and quarantine, self-shielding, social distancing. Snow days is an interesting thing. They've done this with the Ebola outbreak in Sierra Leone, where they would shut down the whole country down for a day or two to try to clear out some of the disease. But it's not an uncommon practice to deal with quote-unquote snow days in which you close down or cancel services such as schools, areas where there's a lot of potential for spread of disease. And then other methods to reduce transmission: hand washing, facial washing, physical barriers such as windows, personal protective equipment, PPE, for healthcare officials, wearing gowns, gloves, eye respiratory protection. These are all not just limited to the flu, but should be done in general as a general health and then hygiene practice. Some of the sources I think are good to look at include, for instance, in Maryland, the Maryland Health Department's flu vaccine flu department, if you're interested in that, but more internationally and more nationally, WHO, Health and Human Services, and CDC have excellent websites as well. That's really it for this lecture. I know it was a lot of information, and I know respiratory diseases are very interesting. Another one that you should be thinking about is things like pneumonia. Is another one that causes a lot of public health issues. So some of these diseases that we didn't discuss, I implore you to look into them and try to find out some of the information about that. But I just wanted to give you again a little bit of a teaser on what are the big ones that are out there and how to deal with these situations. With that, I want to thank you very much.